We're very lucky today to have Dr. Daniel Friedman from NYU School of Medicine presenting the EpiPort webinar on evaluation of diagnostic tests.
All right. So let's get started. There's a fair amount to get through in this lecture, and but stop me at any time if you have a question or something that's not clear. Um, and so this topic of this talk is evaluation of diagnostic tests, and we're going to talk about how to interpret studies of diagnostic tests, including looking at ways of assessing reproducibility and accuracy and utility, and as well as some basics in designing studies of diagnostic tests, talking about gold standards, sample size considerations, and potential sources of bias, and speak about generalizability at the end. And at the end, I'll have just an example of a diagnostic test study from the epilepsy literature to illustrate some of the concepts we're going to discuss. So by way of introduction, a diagnostic test is a assay of some kind, and it could be a serum assay, an imaging test, an electrophysiological test, a behavioral instrument, an interview, to determine if a subject has a disease, condition, or outcome of interest. And it's typically compared to some gold standard for the condition, or it could be a set of gold standards. Tests, like I said, may include technologies, bioassays, questionnaires, physical exam findings, presence or absence or severity of certain symptoms, or a composite score that includes the combination of some of those things above. A diagnostic test is considered a screening test when it's typically applied to asymptomatic individuals to identify a population, a group of patients who have a higher probability of having a disease, and it's typically followed up with a confirmatory diagnostic test. And screening tests should have different characteristics than other kinds of diagnostic tests, because the probability of having the outcome or disease of interest is much lower in this asymptomatic group. So they must be extremely sensitive, and the specificity requirements depend on what kind of population, what the prevalence of the condition of interest is in that population. For the most part, I'm not going to talk about screening tests because they seldom apply in the epilepsy population, but just bring up some requirements. So developing a test. So let's say you are coming up with a serum test for epilepsy diagnosis. So the ideal test should be reliable. So it should have a high degree of reproducibility with different users or different machines that assay the test. It should be accurate or valid. It should be able to distinguish people who have the disease of interest from those who don't have the disease of interest. And it should be generalizable, meaning that it should apply to a large enough population that it has some clinical utility. And obviously it should have some advantage over current practice, whether it's cheaper than current diagnostic modalities, whether it's easier to use or more practical, whether it's less invasive, whether it detects people earlier in the course of their disease, and earlier detection and treatment may make a difference. And it should be able to, it could be able to risk stratify people with a disorder as well. So reliability is an important component of any diagnostic assay, and so are the test results reproducible if within the same subject or sample? If you run a serum sample through your analyzer twice, do you get the same result? If you sample the subject at 2 different time points, do you get the same result? If there's some degree of interpretation of the results, does the same rater interpret the same result correct in the same way each time? And is there reproducibility between different raters or readers in interpreting the same result? So if you have a MRI-based diagnostic test, do 2 neuroradiologists interpret the findings in the same way? There are, like anything in clinical medicine, there are lots of sources of variability. So sources of variability that may affect reliability of a diagnostic test may include between or within subject variability. It may, which may relate to the biological, the spectrum of the biological underlying disorder. It may be in the way the specimens are handled, processed, scored, transformed, whatever it is that you're doing. There may be some variability in how the people interpreting the test perform. And the test itself may have some inherent variability and noise. So how do we measure reproducibility with a test? If the results are continuous, let's say a measure of serum concentration of a compound or some other biophysical measurement or something else that is continuous, we use we measure the same sample on multiple instruments and determine a coefficient of variability, which is the standard deviation of the measurement divided by the mean measurement. For dichotomous results, yes/no results, then we look at concordance rates. So how often is there an agreement? Concordance rates, however, don't take into account the probability of the result. So for instance, if you have a diagnostic test and the likelihood of having a positive result and having disease in your sample is low and both raters know it, they will likely agree that the result is negative most of the time, and there'll be a high concordance rate by chance. So instead, in these situations, we prefer to use something called the Kappa Statistic, and it takes into account the degree of agreement expected by chance. So you can use it for either dichotomous or yes/no type questions or categorical results. So if there's a test with 4 or 5 possible categorical outcomes, it can be used as well. And it compares the results of 2 raters. And the 2 raters can be 2 different raters or the same rater at 2 different time points. And the Kappa statistic equals the proportion of observed agreements, so how often do the 2 raters agree, versus minus the expected agreement by chance, and over 1 minus the expected agreement. And so the range of results you can get for a kappa is -1 when there's there's a complete disagreement. So the raters are always opposite to complete agreement. And if the score is 0, it's a chance alone. So how do you calculate the kappa? This is just an example from a hypothetical diagnostic study test where you have 2 readers and one of 3 possible ratings. And these are so reader 1, and so reader 1 in this case uh, um, rates 1 a total of uh, 13 times. 9 out of those 13 times reader 2 agreed with it, and there was some disagreement in between the readers. So if you just took this row, the expected agreement by chance alone would just be they'd agree with each other 1/3 of the time, and the total number of agreements by chance would be 4.14, 13 divided by 3. So, and we observe 9. And you do this for each of the rows, you get a sum of the chance agreements and the observed agreements, divide both uh, by the total number of ratings, which in this case is 44. That's the sum of all these cells, and you get you'd expect by chance alone 0.33 agreement, and we observed 0.68 agreement. You plug it into the Kappa equation from before. Observed agreement is 0.68, expected agreement is 0.3, and plug it into the equation, and you get a Kappa statistic of 0.53. In how to interpret Kappa results, so Kappa scores of greater than 0.8 are considered excellent. 0.6 to 0.8 are considered good agreement. And then, what this, the example that I showed you is an example of an unweighted Kappa score. And so when you have, and that makes sense to use when you have nominal values. So when you have categories that don't really have a relationship to each other, such as positive, negative, equivocal, yes, no, or something like that. But what if you have an ordinal scale? So so there is a relationship between adjacent categories. So if you rate, symptom severity on a scale of 1 to 5, you are going to give you're going to give more credit when the ratings are close together than they are when they're further apart, in terms of looking at the reliability of the test. And that's when you use a weighted Kappa statistic. So how do you design tests of diagnostic accuracy studies? So like the clinical trials designs you studied before, they can be done in cross-sectional or case-control type studies. The problem with using a case control design is you can't calculate predictive value from case control designs because you don't know the prevalence of the outcome in your cohort very well, and there's a susceptibility to something called spectrum bias, which we'll talk about later. And these kinds of case control designs in studies of diagnostic tests should be sort of reserved for rare disorders where there's you can't do it in a cohort or a cross-sectional study or a cohort study because it's not feasible. The other thing that's important is that the sample that you use in these diagnostic test studies should have a similar risk of having the disease at baseline, and we'll talk a little bit more about that later. When you're talking about prognostic test studies, which are essentially the same test except the results will give some information about some future outcome. These have to incorporate an element of time, and so that these are typically cohort studies. Perhaps the most important thing in designing a study of a diagnostic test is picking the gold standard reference. What is the truth? So is there perhaps a standard independently verifiable outcome that you can use? So some cases it may be a biopsy result or another more costly invasive test that you're trying to supersede. Other requirements, it must be independently verifiable. So somebody just looking at that result can make an accurate assessment of presence of the outcome. It must be accepted by the community as being a gold standard. And it must be applied in the same fashion regardless of the result of your proposed study test. And most importantly, it must be interpreted blindly and independently of the results of the test under consideration. So one of the things that we want to determine in such a study is the accuracy of the test and whether it has the ability to discriminate between patients who have the disease and patients without the disease or outcome of interest. The disease is determined by a gold standard test, as we mentioned. And if the results yield a dichotomous value, you do your analysis in a 2x2 table. You could estimate confidence intervals using a binomial distribution or Gaussian estimate. And you can determine for the test sensitivity and specificity. And for the test in the population used, you could determine a predictive value. You can and the other result that you can get from a diagnostic test study of a dichotomous test is a likelihood ratio, which we'll talk about. So this is the sort of standard 2x2 table that you would see in a hypothetical diagnostic test study where you have all the patients that have the outcome assessed by gold standard test. In the first column, that don't have the outcome assessed by the gold standard test. In the second column, and the first row is the people for whom your study test is positive, and the second row is for people for whom your study test is negative. The true positives are people for whom the study test is positive and actually have the disease of interest. The true negatives are the people for whom the study test is negative and don't have the disease. And inherent into the property of the test are two things: the sensitivity, so the ability of the test to identify correctly those who have the disease. So it's the probability of having a positive test when you're disease positive, or A divided by A plus C. And specificity, the ability of the test to identify correctly those who do not have the disease. So the probability of having a negative test and being truly free of the disease, or D divided by B plus C. And so here's some examples of how we calculate it. This is actually a very handy website that allows you to do calculations of diagnostic tests. Let's say we do a study with 500 patients. 100 of them have the disease, 400 of them don't. Our test was positive in 50%, in 50 patients who had the disease. For patients who didn't have the disease, negative in 50 who had the disease, and 396 who didn't. And so when you plug those into that formula, our sensitivity, which is just this divided by this, is 50%. And our specificity which is this divided by this is 0.99. And the test is fairly specific, but not very sensitive. Let's say our test is a little better, and now it can identify 90% of and 90 out of 100 of people who had the disease present. And so the sensitivity goes up to 90%. So those two values, sensitivity and specificity, are properties of the test, and should be the same, no matter what the population that that you apply the test to. And then, but there are properties of the test in the sample that that the test was studied in, and that's called the predictive value. So that is, so there's positive predictive values, the proportion of the patients who test positive who actually have the disease, and that's people who test positive and have disease positive over the total number of patients who had the positive disease. And negative predictive value, the ability of the test to identify correctly those who do not have the disease, so probability of being disease, having a negative test and being disease negative. And just a reminder, again, this can only be done in cross-sectional studies. You can't calculate it in case control studies because you don't really understand the prevalence of the disease in the population. So here's an example of it calculated in a hypothetical population. So we have a study where the prevalence of the disease in our sample is 30%, and the sensitivity of the test is 75%, specificity is 80%. We still have 500 patients. And so based on that calculation, the positive predictive value of this test in this population is 0.62. So if you have a positive test in this group, you're 62% likely to have the disease, and negative predictive value is 88%. So if your test is negative, chances are high that you don't have the disease, but not absolute zero. Now same test parameters, so sensitivity and specificity are the same as in the prior example, and the only thing we've changed is the prevalence of the disease in the sample. It's now 3% in the sample. So so now the likelihood that a positive test represents a true positive is dropped down to just 10%, and the negative predictive value has increased, and that's solely because of the fact that the prevalence of disorder is so low in the sample that most of the time a positive test is actually a false positive test. The other thing that is a property of the test itself is the likelihood ratio, and that's the the probability that someone has with the test has the disease, which is a positive likelihood ratio, 1 over a sensitivity over 1 minus the specificity, and then a negative likelihood ratio, meaning that the likelihood if you have a negative result that you don't have the disease. And based on the likelihood ratio, you can calculate the probability of having the disease based on the pretest probability, or what the known prevalence of the disease in that population. So here's just some examples. So let's say you have our first example. We had hypothetical prevalence of 30%. So everybody, before they get the test, gets has a 30% chance of having the disease. Then based on our sensitivity and specificity values, having a positive test gives you a likelihood ratio of about 5 of having the disease. So now somebody with a positive test in this population goes from a 30% chance of having the disease to a 60% chance of having the disease based on this nomogram. And if you have a negative test, the negative likelihood ratio is about 0.3, and your chance of having the disorder goes from 30% to about 10%. So this is actually an example of sort of Bayesian statistics where you have pre-test probability, a test result, and a posterior or post-test probability. Here's another example with the second calculation I showed that had a much lower baseline prevalence of disorder. So in this patient population, you just prior to getting the test done, you only have a 3% chance of having the disorder, and with the same likelihood ratios, if a positive test result increases that chance up to 10%. A negative test result actually doesn't have a very significant impact on that test result. And you can see actually here some confidence intervals from this calculator, which can be useful. So what we talked about before, mostly for dichotomous test results. So that could be put into a 2x2 table: yes, no, a positive, negative, that kind of thing. But a lot of our test results don't yield yes/no results. For instance, you may have a laboratory measurement that's continuous, or a scale, a score on a questionnaire, or results may be categorical in some ordinal way. And therefore, it's you want to figure in these kinds of studies, you want to figure out, well, what's the optimal cut point? Where do I draw the line to define what a positive test result is? And that may be different for different purposes. And so, for instance, in this example here, the x-axis is of a hypothetical result is a linear scale. Let's say it's a blood test result. Everybody who doesn't have the disease had a result within this range, and people who had the disease had the result within this range. And to define a positive test result, you need to set a cut point, and you could have different cut points depending on your needs. So if you set your cut point here, you have a test with high sensitivity. You will identify everybody who has the disorder, but at the same time, you sacrifice some degree of specificity, because you'll get a lot of people who don't have the disorder that will have a test that's positive. On the other hand, if you set the cut point here, you have high degree of specificity, but you sacrifice some sensitivity because you'll have some false negative results. So how do you determine what the optimal cut point may be? and you use something that's called receiver operating characteristic, or ROC curve. It was a technique that was developed in the 40s for radar detection of planes and missiles. And it's a good graphical way for determining the optimal cutoff for a test, and also to compare tests with continuous or ordinal variables between each other. And it basically is a plot of the number of false positives on the x-axis and the number of true positives and the proportion of true positives on the y-axis at each potential cutoff point. And a test that has some good performance should have a curve that sort of approaches this upper left corner. And a worthless test, a test that has no ability to differentiate between those with disease and without disease at any cut point, has a diagonal line. So this is just an example. It's another good website for doing analysis and playing around with analysis. This is a hypothetical test that has 10 different levels, and this is the number of people with who have scored positively and negatively on at each level. And so now you could calculate if you have a hypothetical cutoff point between each level, what the sensitivity and specificity is at those points, just like using your 2x2 table example, or this calculator will do it for you, and then plot a ROC curve for this hypothetical test. So, and then you could also calculate level-specific likelihood ratios, both positive and negative, along with confidence. So, how do you report the results of ROC curve? You can calculate a summary statistic called area under the curve, or area, which is just basically is a summary of the accuracy of the test, which is true positive with true negative over total positive and negative. It's graphically, it's just everything that's under that ROC curve. An AUC of 0.5 is a poor test. An AUC approaching 1 is an excellent test. And so you can use that to compare the characteristics of two different assays in the same population, which one, if you have two tests to choose from, which one's better, or compare the performance of the same test in two different populations. So some comments on potential sources of bias in studies of diagnostic tests. Spectrum bias. So that perhaps for diagnostic tests is one of the main sticking points. The characteristics of the test are related to the population being studied. So patients with different level of symptoms may have different levels of test value compared to those with little or no symptoms. And in general, for unless you're doing screening tests, you are dealing with patients who have some degree of symptoms, and so there may be issues of disease severity that can that may contaminate the different the results of your diagnostic test. So it's important to look at Table 1 and look at the characteristics of the patients in each group. Another potential source of bias, and big one in retrospective studies uh, um, is that the knowledge of the result of the gold standard test influences the interpretation of the test under study. So if you know the result of the biopsy, you read the chest X-ray in a different way. And this is, purely because of lack of blinding and lack of independent verification of the gold standard. Another potential source of bias is that knowledge. If you know the results of the test that you're being studied, you treat the people differently, especially when it comes to application of the gold standard test, and it can occur if, especially if there's a lack of blinding and independent verification, and can cause you to overestimate the accuracy of your studied test. Other methodological issues that can arise in diagnostic test studies. No tests are perfect, and sometimes you get indeterminate results, quantity not sufficient of a lab test, or some other technical problems. You have to be careful and make sure that you include those in your final analysis, and because it may bias the results if they're omitted. Sample size issues. You want to make sure that just like any other clinical study, that that you have a large enough sample to address the question, the research question you're asking. To make sure that the confidence intervals of sensitivity and specificity are narrow enough for you to make the determination of whether this is truly indeed a useful test or not. So if you do a diagnostic test study and it's 78% sensitive, that may be good, but if at the same time your lower confidence level, a 95% confidence level is 50%, that test may not be perform as well as you think. And tests with poor accuracy, they may just be more accurate by chance. And then the other issue is, can this test that you're applying be generalized? Is it generalizable? What may impact its generalizability? Does it require special expertise? That is not translatable? Is the patient population under study representative of the patient population that you wish to apply this test in the future, and so on and so forth. I have one question. Hold on. So somebody, and it's a good point because I'm just going to go on to the example. So somebody asked, how can you tell the pretest probability in a subspecialty clinic is different from the general population? That's important, right? So your pretest, so you have to understand who your population is. So you want to know, let's say you're interested in asking the question of, do I have a questionnaire that can accurately identify sexual dysfunction in patients with epilepsy? And prior studies have shown that 40% of patients in an epilepsy clinic report some degree of sexual dysfunction, and you don't know what that prevalence is in the general epilepsy population. So you only, and when you do your study, you only understand the pretest probability in your population, and you can only discuss positive, negative predictive value in your population. that theoretically, if other issues of generalizability of the population are are the same, which they're probably not in this case, um, the sensitivity and specificity of the instrument should be similar regardless of what the pre and post-test pre-test probability is of prevalence in the population. Few minutes, I'm going to walk through an example of a diagnostic test study, and this is I don't have, the citation got cut off, but this is a paper by Gillum et al. Lancet Neurology, 2006, I believe. It is called the Rapid Detection of Major Depression in Epilepsy, a multi-center study. And they, the authors wanted to develop a screening instrument to identify epilepsy patients with depression in an outpatient setting because this is a very common comorbidity, and identification and treatment of depression in patients with epilepsy has been shown to be a significant benefit to quality of life. The problem was that standard tools, some of which you may be familiar with, like the Beck Depression Inventory or PHQ-9, or various other instruments that are primarily used in the psychiatric setting, can be confounded by some of the effects of anti-epileptic drugs. So a lot of them will have fatigue-related questions, which could be related to drug side effects, and some related to the disease itself, so cognition-related questions. And they wanted to develop prior studies have shown that the symptomatology of depression in patients with epilepsy is a little bit different than expected in the general population. So they developed their own questionnaire called the NITI. It was initially developed based on expert consensus. They did a pilot study where they looked at scores on this test with a longer validated instrument and refined the test. And then, and this is an example of the test. It's for those of you who have not seen it, it's pretty easy to use and pretty easy to administer. There's a 4-point ordinal scale and 6 questions. And they relate to the symptoms occurring over the past 2 weeks, including the day of assessment. They did some after they had their final model. They had an additional pilot testing to look at retest reliability in the same patients, and the correlation coefficient between scores done at two weeks apart was about 0.78, which is to be expected because depressive symptoms fluctuate in people with epilepsy and people with depression in general. So after they developed their questionnaire and looked at its some of its reliability, they created an accuracy study, and the study was a cross-sectional study. They enrolled 205 patients in specialty epilepsy clinics, and they compared the NITI with 2 other, as well as 2 other depression inventories that are not specific to epilepsy, CSD and the Beck Depression Index. They compared it with their gold standard, which was a structured interview for DSM-4 diagnosis, or the SCID, which is essentially a very regimented set of interviews that are used widely in studies in psychiatric disorders, including depression. So this was their results in the initial cohort. So remember that the test has a score, and so you can and the score is ordinal. So you can create a ROC curve. And you can see here that, like in the example from the lecture, the ROC curve has the favorable property of kind of hugging the upper left corner. And here, just an example, they looked at the sensitivity and specificity at different cut points and the negative and positive predictive value in their patient population. They calculated the area under the curve, 0.94, which is pretty good, and you could create a confidence interval around that estimate. So what's the optimal cutoff value? And is this a good screening test? Why or why not? So the optimal cutoff value depends on what you want to do. You want a cutoff value that has minimizes that has a pretty good predictive value, and so basically you want to, in this population, you want to test a cutoff value that identifies most of the people with depression, or without having a lot of false positives that will require additional psychiatric referrals and work to differentiate them from depressed versus not depressed. And the question is this a good screening test? So in a screening test, you want to be able to efficiently eliminate the people who you don't need to have additional testing. And so what you want to come up with is a test and a cutoff value that has a fairly high negative predictive value, and so meaning that if you score below that value, you're unlikely to have the disease, and we don't have to worry about you anymore. At the same time, you want to have a moderately good positive predictive value, because you don't want to, let's say the result of this test would determine whether you got referred to a psychiatrist. You don't want to necessarily overwhelm your psychiatrist with too many people who, in the end, don't actually have depression either. So for a screening test, you want to have some intermediate level, and the level that they chose was actually 15, because the negative predictive value was good, and was very good, and the positive predictive value was fair. Then they did a second study of the test in a validation sample, and this sample was a little different in the sense that these are already people who had some depressive symptoms. So your pretest probability was already higher, and so these were epilepsy clinic patients that had that reported some complaints, subjective complaints of depressed mood or other symptomatology, and they applied the NITI, and they used a cutoff score of 15. And in this validation sample, the sensitivity was 73, specificity was 72. The negative predictive value was slightly less at this cut point than in the undifferentiated epilepsy clinic group, and a positive predictive value was fair. So they, using this cut point, they were able to weed out most, but not all, the people who actually weren't depressed. But there were still people who scored above 15 in the NITI that actually in the end were not depressed. So why the differences? You know, are the groups aren't really the same. So the test may the performance of the test may differ itself, and that's why you may have different in sensitivity or specificity. However, you know, the sample size issues, you know, sample size issues preclude saying that one test performed worse than the other. And the other thing, what are the potential biases in this study? How were the patients selected? You know, how did the how was the test administered differently, knowing that the patient already endorsed some depressive symptomatology. So that is, I guess, the end of the talk. I'm a little early. Here, and I guess you guys will get a copy of these presentations in the end. There's some references to use, but more importantly, some links to websites with calculators that you can play around with or use when you're if you're designing your own studies of diagnostic tests. And with that, I am happy to take any questions, either by voice or by text.
Thank you, Dan. Do you have any questions?
Oh, here's one question from now.
Oh, there we go.
Does likelihood ratio calculation require Gaussian distribution? Gaussian, maybe clarify Gaussian distributions of meaning, do you need to have a normal distribution of test results, or no, it doesn't. It doesn't. That's not necessary. It's just a ratio test. It's just a simple ratio. So another good question is, how would you approach the cost effectiveness of a test? So it's a good question, and you know, it takes a little bit of modeling. So in part, a cost effectiveness of the test has to do with what happens after the test. So you balance the cost of a false positive test. So you know, what are the potential costs associated with subsequent testing, treatments, and things like that if the test is falsely positive, with the potential reduced cost of a true positive test that supersedes perhaps a more expensive gold standard test, or you know, catches people earlier in the course of the disease before the disease becomes harder or more expensive to treat.
Okay, great. Thanks so much, Dan.
Thank you, everybody. Enjoy the rest of your day.
All right, you too. Thanks, everyone.